primo, senza perdere tempo, do il benvenuto con molto piacere a un collega, Tim Walrave, psichiatra, viene dall'Olanda. Lui lavora in 2 ospedali dell'est dell'Olanda, dove c'è un'unità di psichiatria per la mamma e il bambino. Vi prego, prendete posto, così cominciamo. E quindi, come vi dicevo, uno psichiatra, e farà una relazione sull'allattamento come fattore protettivo contro la depressione del postparto. E ci è venuto in mente di invitarlo perché l'abbiamo sentito parlare in Olanda un anno fa e ci sembrava che potesse portare degli elementi nuovi in quello che almeno è un po' il sentire comune che a volte anche i clinici si trovano a affrontare quando c'è una mamma stanca che forse sembra depressa e si dice vabbè, adesso non le romperemo mica anche con l'allattamento che così si stanca ancora di più. Lui dà degli elementi che possono suggerire un approccio diverso. Io sarò inflessibile con i tempi, quindi please Tim, the floor is yours. E lui ha una lettura magistrale, quindi ha 50 minuti, ha più tempo, però anche dopo la sua presentazione come quella della Murray avremo un po' di minuti per le domande. So, welcome and thank you.
Grazie, grazie. Sono molto onorato di essere qui con voi in Bologna, but my Italian is unfortunately not so good, so I would like to speak in English to you. I am a psychiatrist from Holland, and I'm the head of the department of the mother-baby unit, and we admit the postpartum women with the baby when there is a depression or a postpartum psychosis. It is wonderful to be here in Emilia, Romagna. I think this is the place of Italy. It is the gastronomic and culinary center of Italy. I think Bologna is the food capital of Italy. It is marvelous to see. And thank you. And it is so nice to see that the Emilia-Romagna nurtures Italy and gives the best food to Italy, as does the mother who gives, with the breastfeeding, the best food to the baby. And this is a parallel, I think. And first of all, I would like to start. My lovely wife and I, we have 5 children, and after the birth of the eldest, grazie mille. And the eldest is the 15, and when Maximilian was born, well, in the pregnancy, my wife had never had psychiatric illness or anything. She really became sad and withdrawn, and after the birth of Max, she became depressed. And I was very sad and confused, and I felt very powerless. But fortunately, she's a very strong woman, and after 2 or 3 months, she recovered from it. But it made a big impression on me, and we are fortunate to get more children. But after the birth of our daughter, she is 7 years old now, there was a recurrence of the postpartum depression. My wife had this again. She had this twice. So I always feel sorry for people who suffer from a depression. It can happen to everyone, and some people have backache, or some people are vulnerable for diabetes, but some people are vulnerable for depression due to the hormonal changes. I would like to start in my talk with, first of all, to point out the different aspects of maternal mental health, and then I would like to go to the core business of my presentation, breastfeeding as a protective factor against postpartum depression. We will talk about the breastfeeding and about the mechanisms of action. First of all, it is always good to realize that there is a time lapse. So when the baby is born, normally on the 4th day, on day 4, there are a lot of hormonal changes, and the mother can feel sort of sad, or can be sort of emotionally distressed, or the baby is born. There is a relief, of course, but on day 4 is a vulnerable day. And we call this the baby blues, the maternity blues. And it is possible all the day that lactation difficulties are come. But this is physiological. This is a natural process. This happens to approximately 60–70% of the women. So this is quite sort of common. And it has a spontaneous release. The postpartum depression, when the mood lowers, this is normally starting at the 4th week. So after a month, the baby is a month old, then the mother can become increasingly depressed or distressed, and there can be sort of an aversion. Oh, the baby is crying again. Oh, I'm not sleeping. It is very severe, and it is a very hard time. And this sort of gradually creeps in, normally sort of after a month, sometimes earlier, and as my colleagues were saying, sometimes already in pregnancy, but then sort of 4 weeks postpartum, it can become more and more severe. The postpartum psychosis is totally different. That is a very rare illness. It only happens 1 or 2 women in 1,000 women who are delivered. So the frequency is very small, but it is a very severe illness. It is very severe because the woman can become disorientated, confused, hallucinations. She can see things other people cannot see. She can think about paranoid ideas, and it is increasingly dangerous condition. This always, well, 95% of postpartum psychosis happens in the first 2 weeks after the birth. But 75% happens in the first week. So it is always at the beginning of the postpartum period, whereas the postpartum depression gradually creeps in later. When we look at the figures, we can see postpartum depression, but when there is no family history, 1 in 8 women will suffer from a mood lowering. 1 in 8, 12.5%. These are large numbers. Most of them, fortunately, are light depressions. So that is good. But there can be also severe postpartum depressions. When there is a family history, when you ask the woman in pregnancy, has your mother had a postpartum depression? Do you have sisters? Do they have children? Did they have a mood lowering? This is important because then your risk factor increases. We always do in the Netherlands at 12 weeks of pregnancy, at then again 20 weeks, and again at 30 weeks we do the screening. We normally do the Edinburgh postpartum depression scale, and we screen, and then people are referred, and we try to normalize the process. Well, the score is quite high. We would advise you to talk to the psychologist, and this as in a matter of routine. Whereas, the sugars are altered. It's a good thing to go to the diabetes specialist, and we try to make it sort of a normal sort of procedure. because there is always this sort of label, psychiatry, oh, I'm not crazy, I'm not going there. No, it's all about vulnerability, and we want to give good care to the mother and to the child. And so that's why we try to normalize it. Postpartum anxiety disorder happens in 5%. Post-traumatic stress disorder, and this is in the postpartum period. So you have to realize that 1.5% of the women, they have suffered a traumatic childbirth. It is the pain, the agony, the powerlessness, and it can be very severe, a childbirth. But we call it traumatic when the woman thinks that she's not going to survive it. That I had this patient last week, and she said to me, well, it was all very stressful. The baby was not coming out. And then the gynecologist said, we have to go to the operating theater for cesarean section. And I looked in the eyes of the gynecologist, and I saw her fear. And immediately I thought, my husband will have to arrange my funeral. The baby will not have a mother anymore. And then we call it a traumatic childbirth, when there is this total convention of death occurring. That's a post-traumatic stress disorder, and we will treat it with EMDR, with eye movement desensitization. And there is the last phenomenon is the postpartum psychosis. Now this happens in 1 or 2 in 1,000 women who have delivered. But when your sister has had a postpartum psychosis, your chance is not 1 or 2 in 1,000, your chance is 300 in 1,000. So it is very important that we know the family history. When we look at the postpartum depression, as we said, it is a serious mental health condition. It really affects the child, as we heard in the brilliant lecture from Professor Murray, and affecting great, large populations, 1 in 8 women. Persistent low mood, these feelings of sadness, feelings of worthlessness, feelings of hopelessness. And there is this sort of social stigma on it. You have a baby, you should be happy. There is this guilt feeling towards the baby. I'm not good enough as a mother to help my baby. And there is this, this fear of talking about it. So it is important to ask the right questions to the mother, to let them feel at ease so that they can talk, because there is this social stigma on depression. And when they talk about it, and we try to normalize it, it happens a lot. It is not your fault. It is a spontaneous occurrence in the brain. Some people are more vulnerable to it. It is a hormonal thing. It is you mustn't blame yourself for it. And then we try to talk about it. It has a great impact on the family life, as I personally. I saw it personally. There's this risk of emotional understimulation of the baby, and it is associated with this impaired mother-baby bonding. And there are the negative long-term effects on the infant's social, emotional, cognitive, and physical development. Now, breastfeeding, it is a protective factor against postpartum depression. There are lots of data from this, and there are studies, and they show that breastfeeding decreases the risk of postpartum depression. Breastfeeding protects against the postpartum depression, And it is also associated with a swifter recovery from the postpartum depression, which, of course, is wonderful. There is this one point I would like to make, and perhaps you have heard of it, and we call it the dysphoric milk ejection reflex. Now, this is an interesting phenomenon, because in the breastfeeding, a lot of people, they associate breastfeeding with positive feelings. But there are a number of women, and they have strong negative emotions, dysphoria. They feel really sad just before the release of the milk. It normally lasts about half a minute to 1.5 minutes, 30 to 90 seconds. It's only short, but it's a sort of a downfeel before the rest of the lactation. And every breastfeeding, it starts again. There's a lot of research about this, and we know that in breastfeeding women, the dopamine levels, they reduce. But in some women, and this is about in 10-15% of the women, the levels of dopamine, they are greatly reduced, they plunge dramatically. And that gives this sort of depressed kickback at the start of the breastfeeding. The dopamine, it's a hormone. It releases endorphins, and it pushes all these feel-good factors into the brain. And a sudden dip of that causes this transient feeling of sadness. And we know that it happens especially in women with ADHD, where dopamine is already lower. Okay, what's very important during the pregnancy is that you discuss with the woman what her intentions are. What are your intentions? What would you like to do with the breastfeeding? And because if the intention is to breastfeed, and then after childbirth, the woman actually breastfeeds the baby, then the risk for postpartum depression is lower. But when there is a breastfeeding intention, and the actual breastfeeding fails, then the postpartum depression risk is higher. So I would say breastfeeding protects against postpartum depression, but breastfeeding failure, yes, that may increase the risk for depression. So you have to discuss the intentions. Normally, we say in Holland, everybody should give breastfeeding, and we try to promote that, but the percentage in the first week is about 80% of the mothers, and then after a month it's about 60%, and then it drops significantly. But there are 3 situations when we are more careful with breastfeeding. First, with mothers who have experienced sexual trauma in the past, and the breastfeeding of the baby can trigger traumatic events from the past. So we discussed this with the mother, and if there was a trauma related to the breasts, and if they have realized that things can come back from the past, and we are more cautious. The other group it's only 1% of the population, obsessive-compulsive disorders. These are mothers, they are very perfectionistic, they want to have control about everything, how much goes in, how much comes out, and they like the bottle. They like to see how many milliliters. Oh, yes. And they are more precise about this. They find it sort of, it's a black hole, this breastfeeding. There's this, am I giving enough? Is it too much? Is it not enough? And that sort of can cause anxiety. We, the traumatized women, we try to avoid the breastfeeding. But with obsessive compulsive disorder, we agree with the breastfeeding, but they need much more coaching and relaxation and reassurance. The last group where we are careful are the mothers with postpartum psychosis. Yes, because one thing really helps with a psychosis, and that is sleep. Sleep that recovers the brain. Now, with breastfeeding, that is difficult because then the sleep is broken. And so in those cases, we see if it is possible to breastfeed, or perhaps we say to the partner, can you have an active role in the night feedings? Your wife, she has to sleep, she has to recover from the psychosis. So this is always a group to be extra alert on. When we look at the maternal mood, we can see that breastfeeding mothers, they experience an increase in positive mood, pre-feeding versus post-feeding. The mood is elevated. Even when they had the dysphoric ejection reflex, the mood afterwards, on the whole, is positive. Bottle-feeding mothers, they, in general, experience more of a decrease in positive mood, pre-feeding versus post-feeding. Yes, so we see that breastfeeding offers short-term and long-term positive effects on the maternal mood. And there is strong evidence that there is an antidepressive effect by breastfeeding, and that's why we are so in favor of it. The breastfeeding duration is inversely related to the postpartum depression. As you can imagine, a number of studies, they reported an association between postpartum depressive symptoms and early weaning. They stop earlier with the breastfeeding or lactation. Women with severe depressive symptoms, they are significantly more likely to discontinue the breastfeeding. This is concluded. So, yes, breastfeeding for many depressed mothers, it can be the only sort of successful feeling of their motherhood. They feel as if they're worthless and they're not happy and they're not enjoying the child, and they try to, but they say, at least I can feed my baby. I give the baby the milk, and I'm not totally worthless. And the breastfeeding is an important factor for their self-esteem. So it is very important. Then, when we look at the dose-response effect of breastfeeding, we see there is strong evidence for fewer maternal sleep difficulties and fewer maternal depressive symptoms with mothers who exclusively breastfeed compared to partially breastfeeding mothers. Yes, so there are all these positive factors with breastfeeding, but still it happens, of course, a lot that there are postpartum depressions in mothers. We, when in the light depressions, we always try a non-medication first. When we try light therapy, it is allowed again from tomorrow onwards. Tomorrow is the 21st of September, and then light therapy is allowed on the northern hemisphere, and up until the 21st of March. And then in the dark season, especially in Holland, it becomes darker and colder and grey and oh dear. Some people are very vulnerable to that, and they are light sensitive to that. So then we give the light therapy. Yes. Would Bologna be on the same altitude as Barcelona? Is it more or less? Yes. Yes. Bologna is sort of the same, or is it lower maybe than? Because in the literature they always say. In the literature they say that yes. Light therapy is useful, and you use the lamp 5 days, 1 hour a day in the morning. But you can also go on holiday south of Barcelona, they say, and south of Bologna, yes. So that's so light therapy. We use it an awful lot in wintertime for maternal depression. We also use cognitive behavioral therapy, and that is that is you focus on the depressive thoughts, and you try to sort of to counter them, and you try to alter them into more positive thoughts. And cognitive behavioral therapy is very helpful. It is very good. Sometimes psychotherapy is needed. This is especially when the mother, she's pregnant, she's feeling depressed symptoms, and she tells about her own youth. And she had an egoistic mother, or a very dramatic, theatrical mother who was egocentric, and she had a youth where there was effective disharmony, or when the needs of the child weren't well addressed to, and there was insecure attachment. And then we sometimes do psychotherapy with great effects. When we look at the Dutch health care guidelines, in Holland, sertraline is the number one advice for postpartum depression, and haloperidol for postpartum psychosis. When it is started in pregnancy, every trimester we check the serum medication blood levels in the plasma to see if the dosage is not too high or too low, that we have an effective therapeutic dose. Yes, so there are, of course, so many factors that a depression can occur. And the depressed mothers, they have a greater risk of feeling unsatisfied with breastfeeding, and they often experience more breastfeeding problems, and the negative perceptions, they lead to reduced breastfeeding. The other, I'm not sure why this is, okay. Yes, so the other thing would be that the breastfeeding would it enhances the mother-child interaction. So there is this psychological effect on breastfeeding. The other point is the neuroendocrine response. During lactation, there are higher levels of oxytocin and prolactin. Now, it is very interesting, this oxytocin, this hormone, which enhances the bonding between mother and child. They are now doing studies in Harvard in the United States, where people have experienced traumatic events, for example, a car crash or something else, and the people are brought in, and they can have sort of acute stress symptoms, and intranasally, they are given puffs of oxytocin. And it is not available yet, but these preliminary data, they show that it could be a very good preventive factor from experience a post-traumatic stress disorder. So it is very interesting. This oxytocin is very important for the recovering of the brain. And and the prolactin as well, it promotes the relaxation during the nursing. It also decreases cortisol levels, and it enhances the sleep. So that is why it is so important. This slide would be just to show you that it is a team effort. Now in Holland we do this for 10 years in our region, and we are with 2 psychiatrists, and we are with 2 gynecologists. But the psychiatrists, the 2, they sort of spread the word to other psychiatrists, and the gynecologists, they sort of spread it in their teams, gynae teams, and the pediatricians, they spread it as well. And we are sort of the center team, and we have, this is in the east of the Netherlands, and we have done all these training sessions with the midwives and with the nurses, community nurses, and with social workers, that they can spot in an early age a depression occurring. And then we see what sort of care is needed. Some people are depressed, but they are single mother, they have financially great difficulties, and they are deprived, or they have a partner who with an insecure attachment, maybe with domestic violence, and there's social issues. Then we go for the social workers, and we try to enhance their position. Sometimes it is more the depression that occurs, and then we have the day clinic, and people come in, the women come in the pregnant group with other pregnant women, or the postpartum groups. We have 4 postpartum groups, and we have 4 pregnancy groups, and they can, and we try to match them on education level, that they have a bit of the same match, and then we try to support their and to empower their mood. Sometimes it's very severe. Sometimes we it doesn't work with a day clinic. Sometimes it is so severe. Then we had, for example, this one woman, and she said, "Well, the gynecologist says I'm pregnant, but I don't think so. I think it's a stone. I think it's a big stone there. It is terrible, and it's making me very sad." And a psychotic depression, and who was convinced of a stone there. Then a day clinic is not enough. Then we admit them to the ward, to the psychiatric ward, and we give them antidepressants, and we give them the proper care to get out of the depression. And sometimes it happens with the postpartum depression, and they are admitted to the mother-baby unit. And I must say, this is, I work in a hospital, and we have 3,500 deliveries on the obs and gynae and per annum. And we have this mother-baby unit with 5 mothers with the babies admitted clinically. And I have this good relationship with the rheumatologist. Now this is, I treasure this man, because he has, in the hospital, he has 2 little swimming pools for his patients with rheumatoid arthritis and with joint problems. And but I sometimes offer him a lunch, and I talk to him, and we have become friends, and very nice. On the Tuesday and Friday afternoon, the mothers from the mother-baby unit, they can go to this warm water bath, and they go for baby swimming. With the father and the mother and the baby, they swim, and the nurse films and afterwards makes a DVD when there are these wonderful eye contact, and the mother smiles maybe for a second, or the baby looks relieved for a second, and we match all these moments, and then we view it back with the mother, because you can say 100 times to a depressed mother, oh, you're doing so well, and you're looking after the baby, and you're looking at the child's signals, and you're doing it so well. But they won't believe you. But when they see it, and then you say, wow, look at it, and you took your time, and you nurturing your baby so well, and you're so loving and caring for the baby, then it can work. So that's a very positive thing. So we have all sort of scala of treatment, and we want to give the proper care for the mother and the baby, and the partner as well, yes. So that is the main issue, that we give good care for the mother and for the partner, most of the time. The father, we try to involve the father on the mother-baby unit. One day is the day for the father, then the mother goes to do different things with girlfriends or with her mother, or she goes maybe relaxation, and then the father does all the nurturing and changes the nappies and does the bath with the baby, because we want the father to be very sort of self-confident with the baby, that the father can look after the baby as well. Sometimes the partner is a mother, is a lesbian couple. This is also perfectly natural, and we and the partner is also trained in good care for the baby, and all the time we sort of respond to the mother. What would the baby want now? Or the baby is crying now, and we change the nappy, and the baby has had the food, and then we use the 5-minute rule. Let the baby cry a little bit. The emotions, they have to go out. Perhaps it is like a sleeping cry, and the baby will cry. And we try to reassure and to make the mother confident, and to stabilize her mood. As a as a sort of a take-home message for you, I would like to mention these things. If you remember them, that will be very helpful. First of all, the history is important. So, have you ever been treated by a psychiatrist? Is there a past history of depression? Is there a history of anxiety, or maybe trauma, or maybe a psychosis? Have you ever been treated by a psychiatrist or a psychologist? So that is, because for you to remember, it's easy. I call them the 3 Ps. And the first P is the past. The past is important, because the past will say things about the risk in the future. So how was the past? Okay, that's important. The second one is pills. And have you ever used antidepressants or benzodiazepines or antipsychotics or lithium? Lithium, of course, for bipolar illness is very important, risk factor, bipolar disease. So have there ever been pills being used, psychopharmaca? And that is important. And the third question, have family relatives ever been treated by a psychiatrist? Yes. So I wanted a P, so I was thinking about parents. So we've got past, we've got pills, and we've got parents. But also other family relatives, a sister or an aunt or an uncle. Because when there is a positive family history, as we've seen, the risk for postpartum psychosis and postpartum depression is a lot higher. So these 3 questions our midwives always have to ask about the past, the pills, and the parents. And then you have to look with the mother, will you be capable and will you be able to look after the baby? How will things go? Will it be all right for you? We had this one schizophrenic woman, and she was homeless, and she was in a deprived situation, and she was living on the streets near the supermarket, and she was begging, and she was pregnant. And she had a friend, and he was homeless as well. And they were sitting there with the 2 begging. And I said to them, well, we want to, we both agree it must be in harmony for the baby, but the baby can't live on the street. It is not possible. And the man looked at me and he said, well, I've just been into the supermarket. I've stolen this maxi-cosi. So are you sure, doctor, can I not keep the baby with us? He said, no, it is not possible. We will ask the social workers and we will have to take the child in custody. But in the meantime, you will also be treated. You have to come to the psychiatric wing. We have to treat. Schizophrenia is a chronic psychotic illness. It's very, very severe. But everything went in harmony because we said to the mother, whatever happens, you will stay the natural mother. You are the biological mother of the baby. The baby will go to a different family, but once every 6 weeks you can visit, and if things go well, we make it once every month. And so in good harmony, you always try to help people. And yes, I would like to thank you for your attention. Thank you very much. Thank you. Thank you.
Grazie Tim anche per essere stato perfettamente nei tempi, anzi anche in anticipo. Quindi abbiamo qualche minuto per le domande. Tim. Yeah. Un attimo, aspettiamo. Is it working?
Yes,
Is
working.
okay?
Yes,
okay.
thank you.
Ok.
Grazie.
Buongiorno.
Grazie.
Mi ha molto colpito che nel percorso olandese non sia mai stata nominata la figura dello psicologo, per cui mi chiedo che ruolo occupa nel vostro modello all'interno di questa fase del ciclo di vita. Grazie.
Grazie. It is a very important, very important factor, because the psychologist is normally, with the midwife, they are the first to select, and they see if psychiatric care is needed or not. So they in our country, they do the sort of the first selection. And so normally the midwife would ask if there are, like, for example, these questions about the past, about pills, about parents. And if there is a yes in one of these questions, then the woman would go to the psychologist. And thank you for the question, because perhaps I haven't emphasized it well enough, but the psychologist normally does the cognitive behavioral therapy, and all the lighter depressions, they are very well cured. But if the depression is more severe, or if there are other problems as well, then we build on from that onwards, and the psychologist refers to the psychiatric outpatients unit, and then they come to our hospital. Yes. Would that be an answer to your question?
Soddisfatta, sì? Altre domande?
Yes? Yes. Yes, yes. And the psychotherapy, as I mentioned, is when there have been disturbances in youth, and when there have been affective disorders or disharmony. And then we use psychotherapy as well. We used a lot in, and mainly in pregnancy already, to prevent the postpartum depression. Yes, thank you.
Altre domande? La realtà in cui lavora Tim, non so, è una realtà specifica in cui c'è proprio un'unità psichiatrica all'interno dell'ospedale, quindi c'è la parte forse su cui si soffermava la collega, è la parte prima, lui lavora in questo ospedale, per chiarire. Faccio io una domanda, è patrimonio comune? Perché probabilmente il mio osservatorio, faccio io una domanda a voi e basta il mormorio, il mio osservatorio forse è selettivo e probabilmente non rispecchia la realtà, ma c'è fra gli operatori l'idea che appunto che l'allattamento non è un fattore che aggrava la salute della madre, che la rende stanca, depressa, non la fa dormire, ma può essere uno strumento, un intervento, perché secondo me siamo un po' lontani da questa idea che invece il dottor Tim Walrave dà un po' per scontata, perché ci sono gli studi e perché loro la usano. In questo setting che lui dice, nella piscina calda c'è la madre, il padre e il bambino e ci sono i momenti di allattamento che sono proprio dei momenti terapeutici per loro. È una cosa sentita un po' in questi... Qui ci sono diverse figure professionali, è una cosa sentita, una cosa che sembra una stupidaggine o è una cosa già assunta anche da noi? Il mormorio non c'è, quindi...
Grazie, grazie anche per l'intervento di Simona, perché in realtà è proprio questo il problema, che sono gli operatori che per primi non hanno un po' questa... hanno una difficoltà a vedere l'allattamento come una risorsa nel momento della difficoltà. Vorrei semplicemente dire questo: qualche anno fa in un perfezionamento in psicologia clinica perinatale, non dirò mai in quale università, ma non a Bologna, un neuropsichiatra che parlava di depressione postpartum, alla domanda se l'allattamento fosse un fattore preventivo o comunque insomma di sostegno, ha risposto no, non ci sono evidenze scientifiche, non 800 anni fa, diciamo 4-5 anni fa, per cui cioè sì, c'è una grossa difficoltà. Io mi chiedevo solo, perché immagino che in Olanda però si parta, come dire, il punto di partenza dell'Olanda come servizi e come sostegno alla maternità e alle famiglie è un punto di partenza a cui noi manco siamo arrivati, probabilmente, diciamo, nel nostro sistema. Per cui mi chiedevo, secondo lei, quanto tempo è necessario per arrivare fino lì?
I think it is a wonderful country, your country, and but sometimes in family matters it can be slightly traditional when the man is away or is at work, and the woman has the whole burden of the whole household and all the children, and so it is a matter of politics in the end, where in Holland there is paid paternity leave. So then the father can 1 or 2 days be during the week, be at home and help. And that strongly helps the mother. And so otherwise, with 5 children, it is exhausting. And now, and I have this job where 2 days a week I care for the children and I bring them to school and help. And hopefully that will, and in Scandinavia, it is even much better arranged. And they have months of paternity leave, wonderful system. And I hope that that will also happen. But politically, a lot of things are happening in this country. So I'm not totally aware of all the details. But I do hope that funding is going towards the paternity leave. Yes, I will hope that. Maybe in 2 or 3 years' time. Thank you, grazie.
Allora, se non ci sono altre domande, con questo ottimismo nel cuore, speriamo che l'augurio di Team Walrave porti bene.